Hi, welcome to Mind Matters, the podcast where we talk about mental health, substance use, and what's going on in our world. We're so happy to have you with us today. My name is Wendy McCarty Van Bemmel. I represent our 4 facilities here in Central Florida. We have University Behavioral Center, La Amistad Behavioral Health Services, Palm Point Behavioral, and Central Florida Behavioral. Together, we provide a full continuum of mental health and substance use care, from intensive outpatient all the way through residential levels of care. If there's anything we can help you with, please visit us on the web or give us a call. Most of our facilities are open 24/7. We're super excited to be here today. We're going to be talking about ECT. We're going to learn all about it. And I'd like to start by introducing my co-host with the most, Gabe Fernandez.
Yeah, I'm Gabe Fernandez, community liaison and mental health advocate. Thanks for having me. It's always a pleasure.
Always. And we have Mark. Mark, can you tell us a little bit about yourself?
Hi, my name is Mark Stankiewicz. I am the program manager for ECT, or Electroconvulsive Therapy, at Central Florida Behavioral Hospital.
Awesome. So, first question is an obvious one. What is ECT and is it scary?
So that's a great question. We hear that a lot. ECT, also known as shock treatment, that's what it used to be called, not the way it's portrayed in the movies at all. Extremely therapeutic, extremely effective. It's a great treatment for treatment-resistant depression. Patients don't feel a thing during it. It's a very, very smooth type of treatment. And like I said, not the way it's portrayed, like in One Flew Over the Cuckoo's Nest. Not the way it's portrayed in the way it used to be either. It's come a long ways in technology.
Okay.
Can you tell us what the origins is of
Sure.
ECT?
So ECT, they say it goes back as far as even in the Greek studies. A patient of, I believe it was Aristotle, had a seizure induced by malaria. And afterwards, the patient was more clear, was able to express themselves better, depression was lifted. And so that goes back a long ways. Our modern ECT studies started in the early 1900s. A schizophrenic patient had a seizure out of the blue and was studied by psychiatrists due to his response. Basically what happened, his psychosis was so bad, he was in a catatonic stage. He was in a zombie-like stage. He wasn't talking, wasn't eating, wasn't responding. After the seizure, he was responding. He was more cognitively aware, and he was able to follow commands. And so the psychiatrists started thinking, how can we recreate this? So that's where modern ECT had started back in the early 1900s.
Oh, interesting. I didn't know that. That's really interesting.
So the connection with electricity in the brain, huh?
Yep. Yeah.
So
in the 1920s, that's when it started forming it as to what it is with the electricity. That's how they started treating patients with that. They would induce a seizure with electricity. Patient would have a seizure, and that would help treat the depression and mental health illnesses. Obviously, technology's come a long way since the 1920s. It's a lot safer than it used to be, a lot more therapeutic than the way it used to be as well.
So what's the difference between ECT now and maybe those earlier forms?
Sure. So ECT, the way it used to be, they used an alternating current for the electricity. A lot more direct, a lot more intense, and they would also do what's called bitemporal for everybody, where they'd treat both sides of the brain. People's speech and memories in the left side, so modern technology tries to preserve that by doing what's called right side unilateral treatment. And we don't do an alternating current anymore. We do what's called an ultra-brief micropulse of electricity. It is a 0.3 millisecond pulse of electricity that helps cut down on side effects, help us really zero in on what we're trying to do.
So what does ECT treat, or who would be a good candidate for ECT?
Sure. So a lot of people suffer from mental illness. It does not discriminate. We've had several healthcare workers, therapists, nurses, doctors who have suffered from it, and we've been able to treat them with it. So with depression, we don't want to sit around and wait for a medication to possibly be working, things like that. You try multiple medications, they're not effective, and meanwhile, depression is getting worse and worse. Suicidal thoughts are getting more intense. ECT would be a wonderful treatment for that type of patient.
So if you've tried a bunch of things, it's not working, maybe you've gone to counseling, you've tried different medications, you're not seeing any relief.
Yeah.
Okay.
So treatment-resistant depression, that's the best way to put it.
Okay.
Or if someone has intense suicidal thoughts, they're an immediate risk themselves, then ECT would be a good thing for that as well, because of how quickly and how effective it is overall. It's about 80 to 85% effective for depression.
Oh, wow.
So with someone with intense suicidal thoughts, to wait around to see if a medication is going to work, instead of doing that, we can possibly do ECT, where that will help lift those suicidal thoughts.
That's really cool. What does it entail? Like, can you walk us through the process?
Sure. So a patient can come in with their family member, and they'll come into our ECT suite. We will get them in one of our beds, and we'll do a questionnaire with them, make sure that their memory's intact, just do simple questions like name, date of birth, month, year, and then we'll go ahead and start an IV on them. Then they'll be wheeled into our treatment room, where we have an anesthesiologist, psychiatrist, and treatment nurse with them. We will ask a couple more questions, just make sure that they're okay moving forward, and then we administer the anesthesia. It's general anesthesia that goes through the IV. They're completely asleep for it. They don't feel a thing. Once they're asleep, then we will administer the treatment. Once again, I want to emphasize they will not feel a thing during it. They're completely asleep. We also give a muscle relaxant as well, so they don't hurt themselves during the seizure. Most of the time, we don't see any physical movement at all. Maybe a little bit of a foot flutter or some hand clenching, and it's a 20 to 90-second seizure. And once it's done, we start the recovery process. Patient is then wheeled out to our recovery area. They're awake within minutes. We provide coffee, juice, water, muffins for them. Most of the time, patients don't even realize they had the treatment, and we have them on their way with their loved one.
And then can you tell us about the treatments, like how many is it initially? And
Sure. So we suggest 12 treatments. It's Monday, Wednesday, Friday for a month. That's what we call the acute series or index series. That's studies over years have shown that that's the most effective. Less than that can help with people, but to really help with that depression and keep it at bay, 12 is the most effective. If we go over 12, it kind of plateaus. So that's our sweet spot right there. If it's been deemed successful, we suggest a maintenance program for our patients, which is we want to maintain any type of progress we made. So we'll start spreading out treatments. We do once a week for a couple of weeks, every other week for a couple of weeks, and then once we get to once a month, we suggest that the patient connects with their outpatient psychiatrist and make sure that we're all on the same page. If the psychiatrist feels that they're at a wonderful place, we'll go ahead and stop treatments. Or if the depression's been so severe and we're worried about the depression coming back, we'll continue with the maintenance, where we can go as far as once every 3 months.
How does that feel for the patient, or some of the testimonials that you've received? Like, do you wake up and automatically feel better? Is it a gradual process? Is it different for everyone?
It's different for everyone. In some of our more severe cases, like with the catatonia, we'll see it lifted.
And catatonia is more where you're not connecting with the world at all?
Correct.
Okay.
Yes. But yeah, best way to put it is that zombie-like state.
Okay, gotcha.
The patient is, their depression is so severe, they can't move, they can't take care of themselves, they can't speak, they can't feed themselves. After one treatment, we've seen these patients lift from that, and
wow,
it's very miraculous. For other patients with depression and the suicidal thoughts, usually we'll see the improvement around the 6th treatment.
Okay.
That's our benchmark there. And if we're not seeing the improvement that we like, or if the patient isn't seeing the improvement we like, then we'll maybe adjust the treatment a little bit. We can do different sites for the where we administer the treatment. But we'll always talk with the patient and the family before we change anything up, so everyone's on the same page. And I always equivocate it to, if someone's trying to lose weight, they're trying for months and they feel like nothing's coming off and they get really frustrated. Then one of their friends who hasn't seen them in a while comes and meets with them like, wow, you look great. That patient, the person trying to lose weight, reflects and like, okay, maybe I am looking better. Yeah. It's the same thing with this. A patient who lives with depression, it's constant. They're stuck in it.
Can't get away from it.
Exactly. So they don't have an outside perspective. So when they do ECT, they're not really looking at the minor changes. They're just hoping the depression is completely gone. And that's our goal too. But to get there can be subtle changes. So a family member might say, hey, you're smiling. You haven't smiled to me in years. So something like that. We always want to remind the family members to look out for and remind the patients that, yes, you are on the right track, because those subtleties do add up over a period of time, and that really helps. And then hopefully towards the end of the 12 treatments, the depression is mostly lifted or completely gone.
Now, is it just for depression, or are you treating other things like anxiety, schizophrenia? What diagnoses?
Most of the time, anxiety and depression do go hand in hand. If it's completely just anxiety, it might not be the most effective treatment, but like I said, mostly they're correlated. So if it is related to the depression, once the depression lifts, the anxiety kind of goes away with that. For bipolar disorder, for the depressive side of it, it helps with that. And then for some manic patients, it can help with that too, but we have to be a little bit more careful with that. Sometimes it can make a mania worse. If that happens, then we won't stop the treatments. But we won't do 3 times a week. We'll talk with our psychiatrist. We'll come up with a game plan, and maybe we'll do once a week or twice a week, Monday, Friday, until that mania breaks and they become more stable. We've had that happen a couple times in the past, and we always warn the patient and family members just to keep an eye out for the mania if that does happen.
Are there any other side effects that you see?
Most common side effects happen after the first treatment. Since we do use a muscle relaxant, it does cut down on side effects, but most common are muscle soreness and headache. If that happens, we can always give something in the IV to help prevent it from then on. But I always say it's like going to the gym the first time, long time. Your body's not used to that type of workout, and after each treatment, it gets easier and easier. But what I've heard most commonly is calf soreness and jaw soreness.
Okay.
So I always tell patients just be aware of that. That happens. Get rest, drink plenty of fluids, and they can take Tylenol or ibuprofen as needed, and we can just let us know, and we'll help out and give something IV to help prevent that.
So you and your staff do a lot of work with the educating the patient and the families as well?
Yes. So part of our process is we can do either inpatient or outpatient. If they are outpatient, we do a first-time appointment. It's an education appointment. It's completely free. We don't charge a thing. It's about a 30-minute appointment. We do those on Tuesday and Thursday mornings. They'll come in, watch a 20-minute educational video, and then we'll answer any questions they might have. We always want to make sure that anyone involved with the care is educated as well, so we invite them to come along with the patient as long as the patient's okay with that. And then because, we understand that there's so much bad rep for ECT out in the community, we really want to help lift that, and we want to do our best to educate as many people as possible. Once they are done with that education appointment, we'll provide prescriptions for blood work and EKG. Once we get those results back, then we'll schedule a second appointment, which is also Tuesday and Thursday mornings. That one's about 2 hours long. They will meet with our medical team, make sure they're stable for anesthesia, and then they will meet with our medical director, our psychiatrist, to make sure that we're still on the appropriate plan of care as well. And he'll answer any further questions they might have. So it's all about education. We want to make sure that the patient and the family members know exactly what is going on.
Speaking of education, I've known you for some time, over 10 years, and I remember you sharing a story with me about when you were in college, your nursing professor talking to you about ECT. Can you tell us more about that?
Yes. So I'm from Illinois originally, and I went to nursing school up there. And my mental health rotation, we got to ECT, and my instructor skipped over it. She said it's barbaric. If places do that, they should be shut down. It's just not a good treatment. So as a nursing student, I didn't think anything of it. I just accepted it at face value and continued on. When I got to my boards for nursing, I had a couple questions about ECT. And I thought that was kind of strange. I'm like, why is it on the board if it's barbaric? And then, once again, put that in the back of my mind. And then I worked at a mental health hospital up in Illinois for about a year as a tech, and transferred down to Central Florida Behavioral in the spring of 2011. That's when I started. And that's when I met you. We teched together and everything. Yep. And then in 2014, we opened up our ECT suite, and they asked me to come aboard and help out with that. I'm like, why would I do that? That doesn't make any sense. I've been told this is barbaric. I've seen these movies and how it's been described in media and everything. So I'm like, I really don't want a part of that. So our manager at the time, who helped open up ECT, who has since retired, she's like, no, come over. I'll educate you. We'll have you watch the same video we show the patients, see a few treatments, talk with some of the patients, and then make a decision at that point. So I'm like, okay, I'm up for this. Let's go over there. So I started shadowing there. Absolutely blew me away. Just so impressed with the team, with the results, with the patient testimonials. I actually emailed my professor back and said, I was trying to be very polite about it. I'm like, technology has changed a long time. Look into what ECT is now versus what it used to be, because it's a game changer for sure.
Wow.
Yeah.
As you say, game changer, can you describe what you're seeing, or tell us about a success story?
Sure. So just last year, we had I had a wife of a patient call me up, a potential patient call me up. Her husband, per her and him, didn't really have much depression, had a good job, family, couple kids, and out of the blue, depression hit him really hard, to the point where he was what we call thought blocking. He couldn't get any words out. He was like stuck in his own thoughts. The depression was so bad. Well, that scared him, scared his family. It scared him to the point where he thought that's how it was going to be the rest of his life. So he actually had a very serious suicide attempt. He spent some time up in Mayo Clinic getting medical help and everything. And they contacted us and said ECT would be perfect for him. Can we get him down there and get him started right away? So we invited his wife and him to come down and do the education portion. When I first met him, could barely get a word out, no eye contact. Our workup usually takes about an hour or two to do. It took about 5 hours because he was so stuck in his thoughts. I could see the frustration on his end. He was just frustrated with himself. And he got through it, though. He did well with it. And then he came for his first treatment. Still the same, no eye contact, just stuck in his thoughts. Had a wonderful first treatment, had him on his way with his wife. They came back for the second treatment. I didn't recognize him. He walked in the door, immediately shook my hand, smiled. I'm like, who is this guy? Do we have the right patient? Because it was just absolutely incredible. One treatment, he did extremely well. His progress was actually so good. His outpatient psychiatrist and our team were talking. We only did 8 treatments, and he did phenomenally with it. And we keep an account open for 3 months after the last treatment, just to make sure if they do have any relapse or anything like that, we can get them in right away. He did not need that.
That's amazing.
Back to work.
Truly amazing for the whole family.
Yeah.
Now, do you recommend also continuing counseling and psychotropic medications while you're doing ECT or after ECT?
Yes, definitely. So we want to see a whole approach. Therapy is absolutely wonderful, and I would recommend it for anybody. It's really individualized and really helps because mental health illness is very individualized as well. It's not just, everyone's depressed or everyone has bipolar, this, that. Everyone's going through a different struggle, and that's where therapy definitely comes into play. And medications play their part too. They augment the effectiveness of ECT. They basically help us get a couple more percentage points of effectiveness with ECT. So every situation, every treatment plays its part. We we don't change medications through ECT. That's why we recommend that someone has an outpatient psychiatrist if they do come to us, just so that person can continue to spearhead the treatment, and we will touch base with them, make sure everyone's on the same page. So, and I strongly recommend if someone's not in therapy during the ECT treatments, looking into therapy afterwards. It seems kind of counterintuitive to do ECT or to do therapy when you're feeling better, but I feel like that's probably one of the best times to do therapy, because when someone's depressed, it's very tough to focus on things. When they're feeling better, they're feeling themselves, that therapy can help keep that depression at bay too.
Yeah, it almost seems like ECT opens the door, allows you to get to a place where you can benefit from therapy, kind of rejoin your community, your world, and then work on maybe some of those stressors too, because I'm sure you still have those in your life, but you're just at a place where you can work through them.
Yes.
Okay.
Yeah.
That makes sense.
Yeah. I know a lot of our staff on the inpatient setting really enjoy seeing patients, do the ECT because it works so effective and so quickly. Also, I can tell you, we've had patients that have been hospitalized, 13, 14, 15 times in a year. And then, ECT gets recommended and then we don't see them again, or they'll come back every now and then for maybe IOP, but they're not hospitalized anymore.
That's amazing.
Yep.
That's truly amazing.
So we've been open for 10 years, ECT has, and I used to work on one of the inpatient units prior to. And I would have a patient whose depression was so bad, he was on my unit a lot. He wouldn't get out of bed, wouldn't take care of himself. He was one of our first couple of patients that started ECT. And he's been doing maintenance ECT for over 10 years now. He comes once every 3 months. He hasn't been inpatient since. He got his life back. His wife got her life back as well, and we see them once every 3 months, and they're still doing phenomenally.
So I know we talked a little bit about this, but what's actually going on inside your brain when that electricity is hitting that side of the brain? Like, is it activating something? Is it connecting synapses? What's going on?
So with mental health, a lot of research has been poured into it, and especially with ECT since it's been around for so long. So one of the most accepted theories of ECT is what it does is it's basically using electricity to reopen the neural pathways in the brain. It's helping the brain reconnect with itself, recommunicate. When someone is depressed, the synapses aren't firing correctly, or they're absorbing too much of the chemicals associated with mental health illness, or they don't have enough receptors to help compensate for the mental health illness. So basically what ECT does is with that wave of electricity, it's resetting. It's like rebooting your computer if it's not functioning properly. So ECT is rebooting the brain in a sense. It doesn't shut off your brain or anything like that, but it does help reset some of those synapses and open up those neural pathways. Medications were actually created to mirror the effect of ECT because ECT was so effective. So ECT is the more direct way to help treat these mental health illnesses.
Huh. Very cool.
Yep.
That's awesome.
And I know you were saying it can be done on an inpatient or outpatient basis. Also, can you tell us about the transportation part of it?
Sure. So we can start either inpatient or outpatient, or let's say someone's outpatient and it's just getting to ECT has been kind of tough for them, or their depression was worse than they thought after a treatment or so. We can always switch to inpatient and then go back to outpatient once they're a little bit more stable, or vice versa. If they start inpatient and they stabilize, we can continue the treatments outpatient, finish up. So because the patient is receiving anesthesia 3 times a week, they can't drive during the series of treatments for the whole month. It's a bit of a commitment, but because it's so effective, we highly encourage someone to think about the pros and cons of that. But having said that, we do provide a complimentary transport within a 30-mile radius, because we understand that a lot of these patients they still have a life going on. They still they have to get their kids off to school. They have their spouse might be working or something like that, so it might be tough for them to get to our ECT suite. So that's where that that transport comes into play. If they're past the 30-mile radius, we can come up with a game plan with them and their family. Let's say we want we'll come up with a mutual meeting place within a 30-mile radius that's safe, that's open early in the morning. We'll pick them up there. Their family will drive them part way. They'll at this mutual place, and then we'll continue to take them the rest of the way. So this is a good way if they live past that 30-mile radius.
So if someone were to come to Central Florida from out of state, which we've had people do too, they could start that initial time in ECT as well.
Yeah.
With us.
Yeah, we've had several patients come from out of state, from all around the country, actually from outside the country as well. We've had them come and they start with us, or if they if they have if they're snowbirds, if they live at a different location in the country or something like that, and they want to continue with their maintenance ECT, we'll help try and find a place that's in their area. Like, for example, I had a patient who lived in Colorado, came down for the initial 12 treatments, continued maintenance, and then went back to Colorado. We found an ECT suite up there, got in contact with them, sent over all their information and everything, and they continued maintenance up in Colorado. Or vice versa, if they come down, we can do maintenance if they've already been in the maintenance program somewhere else.
So I think it makes sense because your Central Florida is a hospital. You have a full medical suite to start the journey of ECT with you.
Yeah, and not too many places offer ECT. Can you explain the difference between the benefits of having an ECT suite compared to maybe doing it somewhere else?
Yes. So since we are a standalone suite, we're not like hidden in a general medical hospital. Sometimes they do have to book out an OR suite to do their ECT, so they have set limits where they can only take so many patients and everything like that. We don't have a limit of, we never have a wait list. So because we understand depression doesn't wait around, we don't want this patient to sit here on a wait list and then, the depression gets worse and worse. So we'll, we just, as we get connected with the patients, we just add them to the list. We're not going to make someone wait around. And then our suite, it's very easy to find. It's a standalone suite, part of our hospital. It's got its own separate entrance at the outpatient wing of our hospital, so they won't have to go through, navigate, through the ER or something like that. Very easy to find.
Yep.
I love that. As a mom and as a loved one of someone, I can imagine this brings a lot of hope to family members, to wives, to mothers, to husbands, having something that maybe you haven't thought of before, or, you've tried so many different things and it's not working and you start to lose hope. My son's been in inpatient care 4 or 5 times and not going to school. Like, you start to lose hope, and this provides hope. It's interesting.
Yeah. Yeah, we've seen so many people get their families back, their lives back. It's been it's an amazing journey. Actually, our anesthesia group, they've been with us since we've opened. Part of why they love working with us is because they see those improvements as well. They get to know the patients and everything. In a general anesthesia setting, they're usually behind the curtain. They usually don't get to know the patient. It's very impersonal. And our chief of anesthesia said he absolutely loves coming to this because he sees the fruit of his labors. He sees this improvement. It gives him hope as well.
That's going to be neat for you, too.
Yeah, definitely.
I mean, like you're talking about the gentleman that came in and no affect and then came in and shook your hand. Like, that's got to feel good coming home from work at the end of the day.
Oh, definitely. I get goosebumps every time I talk about it. It's just absolutely amazing. It just puts my life into perspective as well. It just makes me so appreciative for everything I have, and it's absolutely incredible to see these families go on these journeys and see a great outcome for them.
Yeah. So what happened with your nurse director? Did she start teaching ECT?
My instructor,
yeah.
I unfortunately didn't receive an email back.
Oh, no!
But I wasn't going to push it. I did my part.
I love the due diligence, right?
Yeah. So I hope I hadn't followed up to see if they did change their curriculum up there. But I did my part to educate. So from that on, it's in my hands. So
I think that's why it's important. Whenever I I tour people through our facility, I always like to show them ECT because, there is such a negative stigma around
Yeah.
it. And, I wish Hollywood would portray like the letters we get from the families saying, thank you. My husband's working on the yard again and smiling and playing
Right.
with the kids, and just seeing the families, how they get impacted,
Yeah. And I'm sure you could go on YouTube and see what ECT looks like today, because I think the common person would think like, someone convulses or, you get this giant jolt
Yeah.
of electricity, and maybe just the education piece of it, knowing what that looks like, seeing the benefits of it. I mean, it could be a game changer.
Yeah. So I was just up at a conference for an international ECT conference just a couple weeks ago, and it's amazing to connect with all these providers who do ECT around the world. I met some doctors from Taiwan, from Germany, from Belgium, Australia, Ireland. ECT is being done all around the world, and to hear their stories and talk about how impactful it is. Hollywood likes to, like we said, kind of glamorize this horrific ECT, but it just really hurts what we're trying to do. And just hearing everyone connect from around the world, it's been absolutely incredible. And I really hope that we kind of go a different path. I mean, horror movies have their place and everything, but,
Sure.
but it also
Everyone
hurts.
likes a good one, but
yeah.
at the same time, you look at modern medicine, it didn't start out as good as it is now. A lot of modern medicine came from very, very humble beginnings, and now we look back on it and we're like, wow.
Yeah.
So it kind of follows the same pattern. When you're at the conference or now, is there any innovations or anything that you're excited about for the future of ECT?
Let me see. It was in Australia. The research that they're doing there, they are working on mapping the brain through an MRI, and they are coming up with what's called e-brain. They use the example. Let's say someone's on lithium. You're not going to start them on the highest dose because that's going to have a lot of side effects. But you don't want to start them on the lowest dose either, because that can take even more time to get the patient stable. Same thing with ECT. With this type of research that they're doing, they want to start at a good setting for the patient where, we're not going to start at a maximum dose, have them, have a prolonged seizure and then increased risk of side effects. And we don't want to start at the lowest either and risk them not having a seizure. So with this, what they're doing, the mapping, the e-brain, it takes into consideration how electricity is dispersed throughout the brain, the thickness of the skull, which also can help with the dispersion of electricity. So it takes all these things into consideration, and they're doing research in that so they can have the most effective ECT possible with the least amount of side effects. So that's what's amazing about ECT and mental health in general, is it's always innovative and always moving forward.
So are you able to see, or has anyone been able to show in a video what's going on inside the brain during the ECT?
They will show before and afters with MRIs. And,
okay, but has anyone done while it's happening?
I would imagine so.
Yeah.
We don't have MRI at Central Florida Behavioral Hospital, so we haven't done that. But
Okay.
I imagine they have. I haven't seen it myself.
Yeah.
But just hearing all these doctors, scientists, and everything with all the amount of research, I'd imagine they have.
Yeah. Very cool. Well, Mark, thank you so much for sharing. I learned beyond what I even knew about ECT, and it's really interesting to see where medicine, where technology is heading in mental health. Thank you so much for sharing your expertise with us.
You're very welcome. I wanted to touch base on one more thing with
Yeah,
ECT.
please.
Probably what everyone worries the most about ECT, memory issues.
Okay.
So that's one of our biggest concerns with when a new patient comes on. They think their memory is going to be wiped, things like that. So because the technology changes, we really minimize that. And like I said earlier, we do what's called right side unilateral treatment. If around the sixth treatment the patient's not feeling an improvement, we can consider both sides bitemporal. But like I said, we'd talk with the patient and the family first before we switch the positions. That's where we might run into some memory issues. Generally, what we see is what we call recall memory. They might forget why they went into a room or what they had for dinner the night before. But some patients say with their depression and anxiety, they suffer through that anyways. So some patients report to us their memory actually gets better with ECT because the depression and anxiety is lifting and they can focus a little bit better. But if they do experience those memory issues, the recall memory issues, those aren't permanent.
Okay.
Generally, once we go to the maintenance program, those lift and their memory comes more intact. There is a extremely small risk of permanent long-term memory issues. We've had one patient in the thousands we've treated who has experienced that. She was actually a therapist, and the way she looked at it was a very therapist point of view. She said her depression was so bad, her suicidal thoughts were so bad, she wasn't going to make any new memories because she was determined she was going to take her own life. So with ECT, she no longer had those thoughts, and she said, I did forget some portions of my life. I do have some long-term memory issues, but having said that, I can now make new memories. So I'm very happy that I received the treatment. I am sad that I lost some of those memories, but now I can form those new memories. So that's what's important. Or, like I said, a very therapist way of looking at things.
Yeah,
but,
very much so.
You know, one patient in the thousands we've treated. So a risk, but you know,
Yeah, no, it's good. Thank you for sharing the risks. And if anyone is interested in ECT and wants to come talk to Mark and talk to the treatment team and ask any specific individualized questions, they can do that through the consultation, which is free of charge as well. Central Florida Behavioral is located next to SeaWorld in Orlando, Florida. Thank you so much for being with us today, Mark. I appreciate it. And Gabe, thanks for co-hosting today. Thank you for joining us. Please look at us on our websites. If you have any question about the full continuum of mental health or substance use care, we can help you out. And thank you for joining us today.